everyone. Thanks for having me. I really appreciate your instructor, Dr. Shermer, allowing me to speak with you all and sharing a little bit about my experience as a sleep psychologist. So, my name is Dr. Alex B., and I'm a clinical psychologist. Previously worked as a sleep psychologist at Cleveland Clinic. I did a year of fellowship there. But my current position is actually that of a pain psychologist. So, I am a pain psychologist at the VA here in Louisville. The world of psychology is moving right in tandem with the medical world, so we are also a highly specialized profession. So, in my time spent in behavioral medicine, I learned a lot about the world of insomnia, about the world of sleep apnea, all kinds of sleep disorders. So, I understand that some of that might be valuable to you, and I wanted to be able to share that. Um, so, kudos to all of you who are in your education. This is not easy, and I really admire you for sticking with it. I know how challenging this can be, and hopefully, I can share some pearls of wisdom that you might encounter in your clinical work. So, we know that sleep disorders are so common, and even if it doesn't meet the threshold of a chronic disorder, we know that individuals often are suffering with sleep problems when they hit periods of stress or episodes in their life that are particularly distressing to them. Um, I still work with sleep quite a bit in the area of pain, not quite as much as when I was doing it full time, but sleep problems are everywhere. So, especially if you're working in primary care clinics, if you find yourself in working in family medicine, this is something that you're going to encounter, but you'll encounter it everywhere. And it's important to assess for and it's important to treat. So, let's make sure that we have a solid understanding of what insomnia is, how we treat it, um, and beyond. So, I want to make sure we cover kind of a lot of areas today. So, starting with insomnia, I have a bunch of notes, so I may be doing a little bit of reading at some point, but these are my own notes, and I want to make sure that I cover what I think is important for you all to know. So, in the world of psychology, we can diagnose insomnia. We often term it chronic insomnia, and there are some criteria that we look for when we are determining if someone meets the threshold for insomnia. So, we're looking for someone that has a complaint, right, or a dissatisfaction with their sleep quantity or quality, and is associated with one or more of the following symptoms: difficulty falling asleep, difficulty staying asleep, so that might look like frequent nighttime awakenings, or problems returning to sleep after they do wake up. And then also early morning awakening with the inability to return to sleep. So some people might want to be able to sleep until, say, 6:30 when they get up to go to work, but they cannot sleep past 4 a.m. Right? That's just an example. So really it's kind of this subjective determination that someone makes, right? It's not really necessarily an objective determination that they have sleep problems or that their sleep problems are severe. It's really quite subjective. They are the ones who are determining the level of severity and how it impacts their life and their functioning. So, along with insomnia, we're looking generally that for the sleep problems to be present for at least 3 nights a week, that it's present for at least 3 months, again, to meet that clinical threshold, that the sleep difficulty occurs despite adequate opportunity for sleep, right? So somebody may be having some trouble with sleep, but, let's say they have a brand new baby. So that's going to make sleep really difficult. Okay, so this is someone who has ample opportunity for sleep. They just can't quite make that happen. We also want to know that the insomnia isn't better explained by some other sleep-wake disorders. So we want to rule out narcolepsy. We want to rule out parasomnias, other circadian rhythm disorders, which may be present. Those are less common, and something like a delayed sleep phase syndrome is something that you'll definitely see, but is often not diagnosed because people that's more kind of a cultural norm that people go to bed later and want to wake up later. But we can diagnose it if it's causing distress in their life. That the insomnia is not attributable to a substance, and that other kind of co-occurring things like mental disorders, that those don't adequately explain their symptoms. Okay, so you can have a primary insomnia. Now, how does insomnia start and why does it continue, right? So, one of the things that I heard all the time when working as a sleep psychologist was yes, yes. When I got divorced, that was incredibly stressful. And, that stress lasted for months. But it's 10 years now, and I'm happily remarried, and I'm still having sleep issues. But they started then. They started when I got divorced, and they've only maintained. Why is that, right? So people can't make sense of that. Um, and that ends up being really distressing. Not saying that's always the case, but often insomnia will maintain even once the stressor has dissipated or remitted. So, what's up with that? So, we look at predisposing, precipitating, and perpetuating factors of insomnia. So, we think of insomnia kind of within that model. So, people can certainly have predisposing factors for insomnia. They inherit, you know, genetics, right, to have sleep problems. That's very possible, very likely. They may have more of a tendency towards anxiety. They may be kind of wired for that. And then other social factors. So, do they live on a busy street in a busy neighborhood? Do they have a bed partner? Do they have a bed partner who snores, right? Who kind of keeps them awake or wakes them up in the middle of the night? Those are things to consider. Those are social factors that are important in understanding someone's insomnia. Okay, and then precipitating factors. This is usually the place at which we see the onset of insomnia. So be looking for these things when someone starts having trouble sleeping. So the big one is medical diagnoses. Did someone recently have a stroke? Right? Are they struggling with chronic pain? Did they even get a virus and that was keeping them up, and for whatever reason the virus resolved but they're still having trouble sleeping? Okay, so precipitating, medical illnesses. Psychiatric illnesses, right? Do they have this new onset of depression or a new depressive episode? Were they diagnosed with anxiety? Were they diagnosed with bipolar disorder? So you also want to assess for that. And then other stressful life events, right? So divorce, buying a house, having a baby, getting married, right? So the important thing to remember there is that it's not just these kind of negative stressors that impact people's sleep, it's also the positive ones. One might argue that, of course, having a baby or getting married is a really exciting thing. It's also incredibly stressful for so many reasons. And we see the onset of insomnia often start with these kind of stressful, precipitating events. But again, sometimes those things remit, right? The child grows up, all the hustle bustle of the wedding is over, and you've kind of merged lives and merged households, perhaps, right? But you're still having trouble sleeping. So this is really where the treatment for insomnia comes in. We are interested in these perpetuating factors, the things that are maintaining this disorder. So one of those things is excessive time in bed. People spend too much time in bed, okay? So one of the things that I hear all the time is someone will say, I've been having trouble sleeping, so I decided to go to bed early to try and get to sleep sooner. Well, that doesn't work, and we know that it doesn't work. Maybe on the odd chance it works. But it's actually a really bad thing to do, is to try and go to sleep earlier. People then will try and kind of make up for that lack of sleep during the day. So they'll do a bunch of napping, right? Naps can feel good, but for a young, otherwise healthy person, we would really advise to stay away from naps. Naps kill your sleep drive. Okay, so we all have a sleep drive. It's kind of like hunger. So if I didn't eat anything all day until, say, 10 p.m., I would be absolutely ravenous, right? My hunger drive would have increased throughout the day, and as soon as I eat, it burns off. So sleep works the same way. So I wake up at 6 a.m., let's say, right? And my sleep drive has a chance to build and build and build and build and build and build. And then I sleep and it drops off. Okay. So when I nap, if my sleep drive is actively building and I nap, I burn off that sleep drive, right? So I'm kind of starting from zero again wherever I napped, even if it's a short nap. Okay, so tiny recovery naps sometimes are okay, but we really want to stay away from naps that are longer than a half hour. So then what happens? People can't fall asleep at night, right? So people get real into the habit of trying to make themselves feel better during the day, right? Rather than doing the right thing in service of getting a better night's sleep in the evening. So napping helps in that way. Or I'm sorry, not napping helps in that way. So as best you can, try not to nap because that's going to make your night of sleep likely better that evening. The other thing that happens is conditioning. So I'll talk to you a little bit about the conditioning process. It's really fascinating, but our brains and our bodies are so accustomed to the associations that we have with different spaces and different environments. So people often get conditioned to their sleep environment in a way that is negative. So they start to associate the bed and sleep with fear, anxiety, and actually condition themselves to the bed to be awake in the place where they would rather be sleeping. So we'll chat about that. But that's really how we think about insomnia. And it's critical to be screening for this because lack of sleep has huge implications for people's health. That is intuitive to the general public, but especially for those of us in the medical field, we know the effects of lack of sleep, even just a night of sleep, right? So be screening for this, be educating patients on this, okay? Now, this has kind of a dark side. All this awareness of sleep and how important sleep is has also actually been really detrimental to our health. So there is a subset of people whose insomnia is maintained on kind of the fear of not getting enough sleep. So people really start to obsess about their sleep. I would have patients bring in Excel spreadsheets. They were already doing their own sleep tracking, trying to figure it out, trying to solve their sleep issue, and that's really kind of the wrong way to go about it. The more obsessed we become with it, the more intent we are wanting to do something perfectly or in a certain way, generally the worse it's going to be, and sleep is exactly that way. There is a certain point at which worrying about it really and thinking about it and kind of obsessing over your health related to sleep has the opposite effect. So the more we worry about it, the more kind of aroused our nervous system is, and it makes it harder to sleep in general. Okay. All right, so just some basic statistics. How much sleep do we need? Okay, so a newborn, right, might need between 14 and 17 hours, a lot. An infant, anywhere from 12 to 16 hours. A toddler, 11 to 14. A preschooler, 10 to 13. A school-age child, so like age 6 to 12, needs 9 to 12 hours. A teenager needs 8 to 10. An adult, between the ages of 18 and roughly 60 years old, needs 7 or more. And 60, 65, we're looking at between 7 and 9. Okay, so those are general. Everyone has a different sleep need. There are ways to figure that out. We won't necessarily discuss those today. But for the majority of us who are viewing right now, and if you're going to be working with adults, again, that sleep need is generally going to be somewhere between 7 and 9 hours. But again, be careful. People get very hung up on the amount of hours of sleep that they're getting, and we'll talk about that. So what we do know is that sleep disorders are on the rise. No surprise, we are a very stressed culture. We are a very stressed people. An interesting statistic is that anxiety is kind of concurrently on the rise as well. So we're much more anxious than we used to be. So average adult sleeps about 6.9 hours. Okay. 68% of us sleep less than 8 hours on weeknights, and 39% sleep less than 7 hours on weeknights. Okay, so we're not getting great sleep, but we're also very concerned about our sleep. So traditionally, when I'm giving a talk on sleep, I'll show an episode of a show like The Doctors or some other kind of sensationalized media that's talking about sleep and all the horrible things that can happen to you if you don't sleep, right? And so people get really freaked out by that. Sleep is something that people feel should be very much in their control, and when they can't do it right or they can't get an adequate amount, they start to freak out, right? So they get really scared. So again, the truth is that sleep deprivation does contribute to chronic conditions, okay? So there is a 36% increase in risk for colon cancer, 3 times the risk for type 2 diabetes, 48% increase in risk for heart disease, you're at greater risk for high blood pressure, 50% increase in risk for obesity, 33% increase in risk for dementia, depression, anxiety, and you got 3 times the risk of catching a cold, right? So there really are risks to sleep deprivation, okay? So people aren't making this up. They're not concerned for no reason. But when they're so concerned, they actually sleep less. That's a huge problem. So we call that psychophysiological insomnia. Okay, so we can actually kind of term that. It's kind of a subset of insomnia. And it's really worrying about sleep itself. So these are patients who will worry during the day. They're thinking about the evening. They're thinking about nighttime. Am I going to be able to fall asleep? Am I going to be able to stay asleep? They worry when it gets dark outside. Darkness is kind of a cue. It serves as a cue to say, oh my gosh, it's getting dark. I'm going to have to go to sleep soon. I don't know if I'm going to be able to do this, right? So any preparing to go to bed. So maybe they're brushing their teeth, washing their face. They start to get even more aroused because that thing is coming that they want to be able to do so well, but history tells them they haven't been able to do it. Getting into bed, right? So lots of different cues, and people start to become very attuned to this. That's something that, again, perpetuates anxiety, yes, and also their sleep problems. So what happens is, when we're thinking about sleep and we're someone who has this psychophysiological insomnia, we're really worried about sleep, it's that fight or flight arousal. So we become very, fight or flighty. We become really distressed and very, very aroused while in the bed. And that's a problem, right? Because the bed is some place that's supposed to be really comfy and comforting and soothing, and we want to be able to relax in bed. But these are folks who cannot do that because they have been unable to sleep, and then they're subsequently so anxious about even trying to do it. So really, people develop what is essentially a phobic response to the bed. And again, you can pick these people out. You can pick these patients out if you ask them, do you fear going to sleep at night? Or does it make you anxious to think about getting into bed? Psychophysiological insomnia, right? They're really worried about it. So again, worth screening for too, because insomnia is highly comorbid with anxiety, of course, and depression too. And it's not looking so good that an estimated almost 20% of US adults had an anxiety disorder in the last year. They were diagnosed with anxiety disorder. This is really on the rise. And, concurrently sleep disorders just go hand in hand with that. So what do we do? Well, I'll tell you what generally happens. So we are all socialized around medicine, and you all know that better than anyone, that when we're young and we're ill, what do our parents do? Well, maybe they give us some medicine and they take us to the doctor. And then we get a little bit older and we start getting accustomed to taking some Tylenol for a headache. And then we get a little bit older, right? So we are socialized to believe that the thing to kind of cure our ailments is something that's, a medication, a surgery, a procedure, something like that, right? And that's really across the board. So, and that's also our expectation. Of course, this is influenced by media messages, commercials, other messages that we get from friends and family, right? Oh, you can't sleep? Well, you need to go get a sleep medication. Sleep medications are not the devil. So there is a time and a place for sleep medication. And really the truth is that we don't know enough about the long-term effects of sleep medications. And that's kind of why we don't like to use them chronically. Of course, you are going to encounter patients who are on chronic sleep medication. And as best we can, we like to try and taper patients off of those sleep medications. Sedatives and hypnotics can be great for people for short bursts of time when they're enduring particularly stressful times in their life. Among kind of some other time-limited reasons, but we really don't want to see this happening with any real regularity, and certainly we don't want this to turn into kind of a chronic form of treatment. But what happens? People have trouble sleeping, they go to their primary care provider, and they're generally written a script. So We've gotten more cautious about this more recently just because we know a little bit more about the ways in which this medication is metabolized. We understand more about some of the adverse events and risk factors that are present, especially when we're taking this medication with other medications. Of course, this is a big one for me in the world of pain. So, if we have patients who are on sleep medications and opioids, that's a little bit of, that's a bit of a flag. We get concerned about that. So, again, sleep medications are not the devil, but we know that there is something more effective out there with fewer side effects. So, CBTI. What is CBTI? Cognitive Behavior Therapy for Insomnia. It is considered to be the first line of treatment for insomnia. So that's good news, right? We have something to turn to if we're not writing scripts for sedatives and hypnotics, right? We have something to go to. So that's encouraging. I'll talk about some of the limitations of that though too. So oftentimes patients will have questions about melatonin. The research is really limited for the use of melatonin with insomnia. Melatonin can be helpful for especially folks who are more delayed, that delayed sleep phase syndrome we talked about at the beginning. So most common side effects of melatonin tend to be some bad dreams and grogginess. It can increase blood sugar too, so you want to be careful with your diabetic patients. So just because something is over the counter, patients tend to think that it's kind of a free-for-all, that it means that it's safe for everyone, right? And the truth is we really don't know what's in melatonin. It's not regulated the way other medications are, so we don't necessarily know what we're getting, and that's problematic too. So if someone is going to use melatonin, and that is advised, usually low dosages are recommended. So, again, when it's over the counter, people tend to think that it's harmless. It's not necessarily harmless. So what do you do? Well, let's say that you're able to find someone who actually does cognitive behavior therapy for insomnia with patients. That's great. That's the first step. Those folks can be hard to come by. There are some resources available here in the city in Louisville. There are some providers who do CBTI. You want to be able to find someone who's well versed in treating sleep disorders, but it's a very effective treatment. Many patients who are treated with CBTI first never go on to need a sleep medication. That's really remarkable. So oftentimes those patients will complete an initial evaluation with someone who is trained in this modality, like a psychologist. The treatment itself is about 4 to 8 sessions. Again, it's time limited. It's not therapy where you're going and sitting down and digging through your childhood. That's not at all what this is. It's very targeted and, again, short-lived, so it's convenient for patients. And roughly 75% of patients see clinically significant improvement in their sleep. That's remarkable. And with almost no side effects, right? So we do make some adaptations in this particular form of treatment for people who have had strokes, for people who have bipolar disorder. Since you probably won't be providing this treatment, you don't necessarily need to know that, but it's important to know that, even with something that is purely behavioral and cognitive, we also want to be cautious about the ways in which we're treating all patients, because some of the ways in which we engage in something called sleep restriction for this particular form of therapy, that's not so good for people who have had strokes or people who do have bipolar disorder. So those are just exceptions that we make as psychologists. Along the lines of the behavioral treatment, these are things that I wanted to discuss because I do think that these are some things that you'd be able to coach your patients on. These are things that are fairly simple to kind of get down pat, learn the formula for, and coach patients in a way that will make a difference for them. So, of course, most of us are familiar with sleep hygiene, right? These are kind of the hallmark rules of good sleep habits. So what are those? Well, you want to kind of avoid screens right before bed, right? Because of blue light exposure and that suppresses your brain's own melatonin production. So stay away from screens, right? You want to create a sleep routine before going to bed, right? You want to have kind of some wind down time. I think some of the best wisdom that we have in sleep treatment is from how we put children to bed, right? You would never dare look at a toddler and say, okay, it's time for bed, and expect that they'll, go and put themselves to bed. We don't do that, right? We put, them in the bath, and then maybe we have a glass of water and read a book together, and you might snuggle together, put them in a special pair of pajamas, right? We're really accustomed to doing the sleep routine with kids. We have good wind down time, but as adults, we're not so good at it. So, sleep hygiene is essentially stacking the deck in your favor to get a good night of sleep. But it's not the whole story. So, for most patients who have chronic insomnia, right, that their insomnia has just persisted, sleep hygiene matters very little. Your patients who have had chronic insomnia are not going to be interested in hearing about your tips for better sleep, right? They've done all that, right? Sleep hygiene accounts for about 5% of the variance and what makes the difference for people who are not sleeping versus sleeping, okay? So it's not the game changer, but again, it stacks the deck. If people aren't doing those things, right, you want to make sure that they at least have the knowledge and the skills to be able to stack the deck in their favor. The real game changer, in my experience, is something called stimulus control. Stimulus control. The stimulus being the bed or the bedroom environment. Now, again, these are things that you can coach patients on in primary care environments and specialty clinics. These are things that have value for patients and that you can teach them that will likely make a big difference for them. Okay? So remember we talked about how people will often say, I just got a terrible night of sleep. So you know what I'm going to do? I'm going to go to bed at 8 o'clock. And that will allow me to get more sleep, right? But it doesn't work that way. So stimulus control is about creating a positive sleep environment when someone otherwise has kind of a very negative association to the bed or the bedroom. Okay, so for those who have insomnia, the bed is often a very kind of negative stimulus. So we get into bed and, right, we get very anxious about it, we get very nervous about it. What we really want to do is we want to break that association and create a positive kind of sleep association. So one way that we do that is we ask that patients do not go to bed until they are sleepy. And if they wake up in the night and they have been up for 20 minutes or so or more, to get up and out of the bed. This is critical. Again, this is something you can teach patients to do. They'll look at you like, huh, right? I want to be sleeping more. Why wouldn't I go to bed sooner? And why would I get out of the bed, right? That disturbs me. It's cold at night. I don't like it, right? Truly, it's the best thing they could do for their sleep. So what people do, right, is they say, well, normal people go to sleep at, I don't know, 10:30. I should be getting in bed at 10:30, right? So they get in bed at 10:30 and they lay there awake, right? Twiddling their thumbs, looking at the ceiling, wondering when they're going to go to sleep. No, no, no. We want patients going to sleep when they are sleepy. If they are not sleepy until 1 in the morning, don't go to bed until 1 in the morning. Again, they'll look at you like, huh? But again, remember, we are working for sleep drive. So if that patient has to get up at, say, 6:30 in the morning, right, but they don't go to bed until 1, right? No, we're not going to have them sleep in. They're getting up at 6:30 because what that does is that builds that sleep drive. This is why we coach patients to wake up at the same time every single day, no matter what, even on weekends. Because again, your body craves this regularity. It wants that routine so that your sleep drive is predictable and it is strong enough to be able to send you off to sleep, right? If that person who goes to bed at 1 a.m. is accustomed to waking up at 6:30, but then maybe, let me sleep in until 10, right, on a Saturday, their sleep drive is not strong enough, right, the next night. So they're thinking, well, shoot, I gotta kind of get back on track. I gotta go to work. I gotta be ready to get up again at 6:30. If they slept in until 10 o'clock, their sleep drive is not strong enough, right, to fall asleep at a reasonable time, okay? But again, do not go to sleep until you are sleepy. Because what does that do? That reinforces this negative association with the bed, right? Lying awake, your brain learns very quickly, oh, right, this is the place that I come to lay awake. This is the place where, my mind starts racing. This is the place where I, feel just tense and anxious and I'm going over the things that happened to me during my day and, right? The best thing they could do is not go to sleep until they are truly sleepy. And when they wake up in the middle of the night, which many people reliably do, if they find themselves laying awake, get up and out of the bed. Again, we are trying to cut this negative association with the bed. So they get up, we want them to do something really boring. So don't turn on the TV, right? No screens. Don't read a murder mystery, right? So doing things that, can occupy you, like folding laundry, maybe reading a book, right? If it's not too exciting. I've coached patients to just keep catalogs that come in the mail, right? So just keep a stack of J.C. Penney catalogs and look through those, right, in the evening by just dim light. Okay, so something boring. When you start to feel sleepy again, return to the bed. All right. If you can sleep, great. If not, right, another 20 minutes or so goes by, right, up and out of the bed. Okay. That process, if patients are able to be consistent with it, eliminates this negative association with the bed. They learn that, oh, right, this is a place that I can sleep, right? When I'm awake, I go somewhere else. When I'm awake, I go to the couch. I go to the chair in the living room, right? But when I am tired, I go to bed and I fall asleep. So again, this process of not going to bed till sleepy and getting up and out of the bed when awake does that for them. It is amazing how well this works if patients can be consistent with it. So trust me, you will encounter patients who say, nah, I didn't do that because it's hard. It's hard. It's hard to get out of bed. Yeah, it's hard, right? But this is effective. So have them keep a fuzzy blanket, next to the bed or a warm, fluffy robe, especially as we're getting into cooler temperatures, right? Try to make that getting up and out of bed less aversive, right? The important thing is that it is effective. We know it's effective. You just have to be consistent with it. So again, that is something you can coach patients on. Another component of CBTI is sleep restriction. I won't talk with you too much about that. It's a bit of a complicated process, but it's essentially restricting someone's sleep to the time with which, restricting their time in bed to the time with which they sleep. So we track someone's sleep on a sleep diary. So I actually brought an example of that. I don't know how well you can see this, but you can see that we ask patients to track all kinds of things: what time they went to bed, how many times they woke up, about how much time they were up, if it was a good night of sleep, right? So we have patients fill out sleep diaries, we calculate them, and we get a sense of, on average, how much they slept. That's really valuable information because then what we do the next go around is for the next few weeks, we're going to actually restrict their time in bed. Okay, so if they only slept 6 hours, right, on average for a few weeks, they are only going to be able to spend 6 hours in bed. Again, the effect of this is that it really increases this positive association with the bed. It increases their confidence and their self-efficacy that they can sleep again, and it's highly, highly effective. Okay. The fourth component of behavioral treatment is relaxation, right? Because these folks, when they're lying in bed and they're getting nervous about sleep and they haven't been able to sleep for weeks, months, years, right? They're highly physiologically aroused, right? Their sympathetic nervous system is on high alert. So we teach them relaxation techniques that they can do before bed, they could do in bed, they could do in the middle of the night to start to dampen down that sympathetic response, right? To kind of invite conditions for sleep, right? Because when I'm fight or flighty, right, and I'm just so angry that I can't sleep, what's the likelihood that I'm going to fall asleep? It's very unlikely. So we need to employ patients with relaxation techniques. So that's really kind of the behavioral component of CBTI. Again, highly, highly effective if you can find providers who can do it. So I want to see what else I want to say on this. I don't want to go too much into the cognitive component of CBTI. It's a little bit more complex, but really just knowing that our thoughts about sleep are important. So patients tend to catastrophize about their sleep. They'll say, I don't sleep. I just don't sleep. I never go to sleep. Well, that's a catastrophic thought, right? That's actually not true. It would be that's impossible. You would sooner die, right? That if you don't sleep, you're not going to make it. So these people are sleeping. It's just that they're being fairly catastrophic about their appraisals about their sleep. So as psychologists, we really work with the way that people are thinking, right? The thoughts that they have, the statements they make, the attitudes they have. So the more we can help people kind of regulate their thinking around sleep, the more conducive, right, conditions are for them to actually sleep. So we use cognitive behavior techniques to make that happen. So one thing that I thought might be useful is to, if you don't know about this already, this is something to be aware of, the Insomnia Severity Index. So the Insomnia Severity Index is a measure that is likely readily available in lots of medical institutions. I use it all the time when screening for insomnia. Some healthcare spots actually mandate that this is used just because we know so much more about, sleep deprivation. But it's a quick measure, it's a brief measure, it's 7 questions asking patients about their sleep. And this gives us a better sense of where someone falls in terms of the severity of their insomnia. Remember, that's subjective, so it's their perception of their sleep. But this is a really nice screener to get a read on patients. So if you are in a position to screen for insomnia, I would recommend this. Again, it's quick, it's easy, it gives you just a really good snapshot of how someone's sleep is looking. And it asks for the last 2 weeks of severity. So I use this with almost every patient. Again, quick and easy. So one thing I want to do is I want to transition a little bit from talking about insomnia to talking about sleep apnea, which is something that is enormously underdiagnosed. So because I worked in the area of sleep medicine, right, I encountered sleep apnea all the time. It was commonplace. We treated people with sleep apnea all the time. But especially in primary care, we don't do such a good job of identifying patients who have sleep apnea. We don't do a good job of screening for it. And yet sleep apnea has enormous consequences, both short-term and long-term. And again, it is enormously underdiagnosed. I cannot emphasize that enough. So, on the topic of screening, a good screening to use is called the Epworth Sleepiness Scale. Again, if you're in a position to be screening patients for sleep disorders, this is a great thing to toss in. It's only a few questions, and it essentially asks patients how sleepy they are during the day when doing certain activities, or rather, how likely they are to kind of nod off. So, is it, common for them to nod off when they're a passenger in a car? Is it common to nod off when they're sitting quietly watching TV, right? So it will present you with some scenarios. Again, it's only a few questions, but it gives us a score that gives us a better sense if someone may have sleep apnea, okay? Because of course, daytime sleepiness is kind of a hint, right? Now again, we're living in a stressful world. We're all overextended. We're all working a ton. So it would be common for people to say, I'm just feeling tired. And even still, we want to be cognizant that sleep apnea might be, right, a factor at play. So here's the deal. Sleep apnea. So when I was working at Cleveland Clinic, I went to a sleep symposium, and I was absolutely blown away by these numbers. So, 94% of men who have sleep apnea do not know that they have it. 94%. 83% of women who have sleep apnea do not know that they have it. That is remarkable. That is remarkable. I can say with confidence that whenever I've gone to a primary care appointment, nobody has screened me for sleep apnea, right? But again, think of the risk factors. The risk factors are huge. Or rather, the risks involved, the adverse events, the potential adverse events coming down the line for someone who has sleep apnea that is undiagnosed, undertreated, unmanaged. So we want to be screening for this. We want to be on the lookout for sleep apnea, okay? those are crazy numbers. Um, so, sleep apnea, in the short term, of course, makes people sleepy. That's one of the first tip offs that people just say, I feel awful in the morning. Um, I can't concentrate during the day. I could just fall asleep right at any moment, seemingly. So, be on the lookout for that. That's important. Um, but also down the line that sets people up for things like diabetes, heart attack, stroke, right? We know high blood pressure, all of these things that of course we'd love for our patients to avoid, and sleep apnea is a huge culprit. Okay, it's enormous. um, so let me see what I want to mention. So there are a few kind of signs that you want to look for. Okay, so if a patient is either curious about this or you're screening them for it, these are some good things to ask for. All right, so do they snore loudly? So they might have a bed partner, a spouse, a partner who sleeps with them, right? Would they say that they snore loudly in the middle of the night? Do they ever report that that person stopped breathing, that kind of gasping in the middle of the night? Sometimes it's more subtle, right? But is that happening, right? Do you ever wake up with shortness of breath, kind of, right, gasping awake? And again, bed partners tend to have a better awareness of this than the patient does. Do you ever wake up gasping or choking? Waking up to use the bathroom. So listen to this. A lot of times people will say, yeah, I wake up like 6 times a night, but it's because I have to go to the bathroom. That may be the case, especially if it's an older adult. However, this is often what we see with sleep apnea, that they wake up, right? They have these frequent nighttime awakenings that happen with sleep apnea, and they're up, so they sense that they could potentially empty their bladder, and so they go to the bathroom, right? So again, I want your mind to kind of ding. I want you to be thinking about that when someone says they just wake up all the time and they just go to the bathroom all the time, right? Of course, you're ruling out other things, but I want you to be thinking about that too. Waking up with a dry mouth, right, or sore throat, because breathing through the mouth. Waking up with a headache, that's a big one, right, because our brains aren't getting the oxygen that they need if you have sleep apnea. Having insomnia, okay, so that can be kind of a sign. Having, again, memory problems, concentration problems, right, that kind of, we're wondering, okay, what's happening neurologically for this person? But again, consider sleep apnea, right? So there are, of course, risk factors for sleep apnea. Now, kind of the stereotypical view on sleep apnea is that it's only people who are very obese. And that is a risk factor. That is a risk factor. But that's not the whole story. In fact, people who are actually quite thin can have sleep apnea. A lot of it has to do with the facial features, cranial facial features. So if someone has a chin that is set very far back, that is a risk factor. Okay. If someone has a very large neck, a big neck circumference, maybe like 17 inches. Not that you're going to pull out a tape measure, right? But if you can tell that someone has a very thick neck, that is a risk factor because they're more likely to have this obstruction here at night. Okay. Large tonsils, right? That provides another opportunity for obstruction. Another thing we look at is a high arched palate. So if you are looking in someone's mouth and they're talking about, some of these signs, check their palate. If it's a high arched palate, potentially sleep apnea. If you ask them to stick out their tongue, check for signs of scalloping along the edges of the tongue. Scalloping can be a sign, right, of sleep apnea. So, reason being that when someone is sleeping and they're trying to get air but they're choking, right, because they have this obstruction, they start pushing their tongue against their teeth. So, what you'll see is that swell, you'll see inflammation in the tongue, and you'll have these ridges along the side of the tongue. Now, sleep apnea is not the only reason that that can happen, but it's something to look out for, right? You're looking in people's mouths anyway, so check out their tongue, check out their palate too while you're at it. So those are just, again, some signs and risk factors associated with sleep. My hair with this camera. This is a problem. So again, be looking for those things, okay? I can't emphasize enough how detrimental it is that we do not screen people for sleep apnea. The treatment for sleep apnea is not always everyone's favorite, right? Traditionally, we think of a CPAP. Um, There's some people who love their CPAP. They take it everywhere with them when they travel. They use it every single night. They're CPAP loyalists. And there are some people who absolutely hate it. There are people who are phobic of it. I've treated patients for CPAP phobia, right? Because they don't like, this mask on their face. It makes them feel very constrained, and it's kind of scary for them. Um, but you can have people desensitized to it. So one recommendation that you could make, if that was the case, is tell them to put it on during the day. They're watching a favorite TV show, just have them put their mask on, right? It kind of desensitizes them to it. That's not the only solution, though. We can get these mandibular devices through dentists and dentistry that allow the bottom jaw to be pulled forward at night so that it just reduces the obstruction. Those are, I shouldn't say not always, those aren't as frequently covered by insurance as CPAPs are. So the other piece about that too is that insurance companies are often happy to pay for things like sleep studies because they know that in the long run this person is going to cost them less if we get their sleep apnea treated. So don't be afraid, right, to be sending for sleep studies. This is something that is going to benefit your patient in the short term and the long term. The other thing is that there is a device that is implantable. It's called the Inspire. And the Inspire is a device that has an electrode placed in the hypoglossal nerve, and it kind of protrudes the tongue forward to prevent the obstruction. So I've seen these implanted. I've seen them adjusted. It's really kind of weird and sci-fi, but also very cool. You have to also be a candidate for the Inspire, and it's pretty expensive. You have to have failed, other therapies before you move on to that. So, sleep apnea, screen for it, please. Okay, so the other thing I wanted to just mention really briefly, I know that oftentimes patients and providers, for that matter, have questions about sleep trackers, right? So a lot of folks now have Apple Watches, Fitbits, other sleep apps, and they have questions about how effective those are. So, those are very expensive devices. And the bad news is that they're not very effective at measuring sleep. So, sometimes it's kind of cool, right, to get some data on how your sleep might have looked at night, but again, they're not effective. They don't do a really good job of measuring sleep and sleep waves, and they give some sort of estimation sometimes on how deep your sleep was. And again, we've done plenty of studies to know that they're ineffective. What I would say is that for people who just report that they get better sleep using their Fitbit or their Apple Watch or whatever app they're using, more power to them. You keep on with that, right? If that is working for you. I would say more frequently we see patients wearing those trackers for sleep when they have insomnia already. They believe that they should be tracking it more frequently, that if they do, they're going to get better information. It's going to assist them. And usually what I end up doing is telling patients to take them off at night. And they're not happy about that if they just spent a bunch of money on a sleep tracker. But usually it makes them more anxious because what do? They wake up either in the middle of the night or in the morning and they check their sleep tracker, right? Okay, so maybe they think, you know what, that was actually a pretty good night of sleep. And they go to look at their tracker and it says, I only got 3 hours of deep sleep. What? How could that? I felt great. I don't understand. I must not be sleeping so well. So you can see how that just reinforces a lot of the anxiety, reinforces insomnia. So I am generally advising patients to stay away from sleep trackers. So that's my thought on that. There are some good apps, though, for the treatment of insomnia. Okay, so the VA actually has some great free apps that are available for anyone to kind of start getting educated on sleep, on things like sleep hygiene, stimulus control, tracking their sleep. So those are things that they can be doing on their own at home, and a lot of those are free. Um, I would avoid paying tons of money for apps like this. The technology and the formula for getting better sleep really is the same. Um, since I worked at Cleveland Clinic, I don't need to plug them, but I will say that I worked with a program called Go to Sleep that is available if you Google it. It's $40 to do the whole 6-week program, and it's a 6-week course that delivers CBT for insomnia online. So that's something that you could tell patients about. It's something you could do yourself. Again, it's $40, but it is the treatment. So if patients are fairly technologically savvy, that could be a great recommendation for someone who is struggling with insomnia. Um, if there's someone who is not quite as savvy and they would do better face to face, again, there are providers in the community who offer this particular treatment. So, um, you know, you can refer to them. I will try and provide Dr. Shermer with a list of resources on where you might be able to refer patients if that's the case. But again, there are good kind of cost-effective resources available that deliver the same treatment online. There's been some studies. Generally, online treatment programs are just as effective as in-person delivery of those treatment programs. The only difference is, again, you have to be kind of technologically with it, have access to computer and internet. Not everyone does. So those are just some things to think about. But that's really it. So I really appreciate you all letting me be with you tonight and offering some of what I know about sleep. I will ask Dr. Shermer to pass along my contact info. If you have questions, if you want more information about anything, I'm happy to talk to you all about that. So in the meantime, congrats to you. Good luck on your education. You all are doing a great thing and really entering a beautiful field that is in service of other humans. What's better than that? So thank you again, and have a great night.